Hi, and welcome to Session 4. In Session 4, we're going to look at the Prevalence and Incidence Evaluator Training Program, which you have available to your staff online. This training program involves training, testing, and actually gives a certificate if they obtain a score of 75%, which qualifies them as a Prevalence and Incidence Evaluator. The data that they're going to review identifies risk factors and resident population. It identifies the effectiveness of the prevention strategies. It helps provide a perspective for regional and national data collection. It provides the data for comparisons. It supports decisions around resource allocation, and it supports the development of acceptable benchmarks. The reliability and validity process is in 4 parts. Step 1, we have the online training. So all evaluators must go online and obtain competency in pressure ulcer stage recognition. 75% is a pass. Step 2, 2 observers working together assess the residents and gain consensus, and then complete the forms. So 2 people look at the skin and determine what they feel the stage of that pressure ulcer is. Mark down the stage on the form. Step 3, an expert clinician independently assesses 10% of the residents or patients or clients randomly chosen from each unit to ensure accuracy, so that third person goes in, takes a peek, and makes sure there is agreement. Then the data is submitted. So prevalence needs to be completed annually for the Canadian Association of Wound Care program, and incidence is completed weekly for 4 weeks post-prevalence. This is an example of a prevalence study on the left, showing that their baseline was 10.9, and after 1 year they were half, so they had a 50% reduction to 5.0. The incidence on the other side of the screen shows 4.1, and if you can see, the incidence after 1 year dropped to 1.6, so much lower than 50%. So this is a very successful P&I. Here's a sample form of the sheet required for you to collect your prevalence data. So what can happen in prevalence data? Not always does it go down. As we get increased awareness and reporting of pressure ulcers, especially stage 1, it may go up. Also, if you have increased admission of residents, patients, or clients with pressure ulcers, you could see a rise. There could also be difficulties in successful implementation of the program, which won't give you the best results. And unfortunately, errors in data entry do occur on occasion, but they will be followed up with the team leader. Do not backstage. Always assess pressure ulcers at their original greatest depth. So if the pressure ulcer was a stage 4 and it now is shallower, you would refer to it as a healing stage 4. Once healed, they are no longer a stage. So once they are closed, you could say they are a closed stage 4, but they no longer have depth to them. Once a DTI, or deep tissue injury, opens, it is assessed at its greatest depth, which is usually a stage 3 or a stage 4. The PUAP program has a set of accreditation standards, so notification of accreditation will be done via a letter of regret or a letter of congratulations on behalf of the Pressure Ulcer Awareness Program National Team Leader and the Canadian Association of Wound Care. An accreditation certificate and yearly seal will be delivered to facilities that successfully achieve the accreditation standard. Now these following slides are a little bit wordy, and you can feel free if you wish to pause and read them in more detail. But the bottom line is, For accreditation, you need to meet the objectives of the program, which is complete the initial program phases and actively participate in the PUAP process. The actions are to visit the champion member's website a minimum of once a month. This is really important because it connects you with tips and tricks and the latest information that we have to offer. You need to attend 75% of your cohort conference calls on a quarterly basis. You need to collect the pre-program and the first year-end prevalence and incidence data and submit it to the site champion member's website. And you also need to complete a progress report and submit it to your team leader. Now for year 2, it's a little different. We're moving towards sustainability, so we want you to identify the gaps in the program, and that's in Appendix G. So what is missing in your implementation process? And to create a plan to address the gaps using the PI Bridging Barriers tool, and that's on your website. Maintain and improve reductions in the P&I. So actions, you need to complete all of year 1's actions, which we talked about in the previous slide. Attend 75% of the teleconferences, same as before. Submit a biannual self-evaluation tool, and that's in Appendix G, to your team leader. Submit an action plan for continuous improvement in implementation and sustainability using that PI Bridging Barriers tool. And then collect your P&I data at the end of your second year. Now year 3, this is a very busy slide, isn't it? We're really looking at a continuous improvement, and we're making sure that these practice changes are embedded into your organization. So we want you to demonstrate sustainability of the culture shift towards prevention of pressure ulcers using the self-evaluation tool again, which is in Appendix G. Reevaluate again obstacles and barriers using the PI Bridging Barriers tool. Maintain and improve reductions in the P&I, the same as you did at the end of year 1 and year 2. So complete year 1 and year 2 actions, continue to attend your conference calls, submit a biannual evaluation to your team leader, and collect your data. The key elements that have been described as being very important for a prevention program to work have been outlined by the National Pressure Ulcer Advisory Panel, and I just want to review them briefly with you. Raise awareness, make pressure ulcers an issue. We are doing this in a big way. Use an interdisciplinary wound care team. Boy, do we have a good team in you. They ask for certified wound ostomy continence nurses, and what we are trying to do is making sure that our site champions have the most up-to-date knowledge available to make them an excellent resource in their facility. Administrative support, we've done that. Evidence-based prevention protocols, based on RNAO best practice guidelines, we will keep you up to date. Data-driven process, we are measuring P&I. We are measuring our processes. Connecting the dots, correlating pressure ulcer outcomes to compliance with preventative care processes. We are lowering rates through the kind of care that you're giving based on your risk assessment. Repeated measures and trend over time. What we're hoping to do with our P&I data collection is to really watch how prevalence rates change based on good initial assessments and good initial care plans. Education and communication is the cornerstone of our program. Individual and system changes are required. We know that knowledge doesn't change practice. Practice only occurs when the learning has been applied to bedside care, and that's why our care reviews are so important. We want to make sure that the documentation in the charts reflects practice change. We are committed to continuous quality improvement, and reward structure is in place. As you will see in the upcoming sessions, we give certificates when units successfully get the red out. Remember, healing relationships can't be reduced to prepositional statements, nor can they be mandated by contract, yet we know them when we experience them, and we recognize them when they're missing. Thank you.